Hello, Dr. William Berger here. I'm the owner and founder of Northeast Medical Practice. We are a concierge-style internal medicine, weight management, and aesthetics practice located in Great Neck, New York on Long Island. And I wanted to take a moment to tell you again, I've mentioned it before, but tell you a bit about our practice and the services that we offer. So you may have not heard about us before, but we are a very comprehensive concierge style practice. So what that means is that I offer full spectrum primary care, your annual physical, your sick visits, follow-up appointments for regular things, but a whole lot more. And while we are in network with insurance, we are able to bill insurance. The level of care that we provide is considered executive health. So kind of like what you might receive if you were a C-suite person and going to the Mayo Clinic, the Cleveland Clinic, that kind of thing, except that I'm available to you 24/7 unless I'm under general anesthesia and unavailable for that reason. So let me tell you a bit more about it. The annual physical is more comprehensive than what you might receive in a traditional insurance-based primary care practice. And I can say that because I used to be a primary care doctor working for a major hospital system here in the New York City area. So I know exactly what it's like on the other side, if you will. With the 7-minute visit, your doctor's booked out for 3 months. And if you're ill, you're going to see somebody that day who might be a mid-level provider, such as a PA or a nurse practitioner, but not your doctor who knows you well and is your doctor, is a physician. So the physical usually is about 90 minutes or so, sometimes a little bit more, sometimes a little bit less. We do a deep dive, particularly if this is your first visit with us, into your medical history, your family history. Really need to know where you're coming from and what, if any, issues you have. What are your goals for your health and so forth over time? Because the goals of our practice are twofold, I would say. We have two foci beyond the acute care for, somebody's bronchitis or things of that nature. And number one is making sure that you're metabolically healthy. And the way that I like to approach that is by controlling weight. And when I say weight, I really mean adiposity, fat mass, because obesity, due to increased amount of adipose tissue on board, is the mother of all of the chronic metabolic and other diseases that we have in the West. I'm referring here to hypertension, diabetes, hyperlipidemia, meaning high cholesterol, the things that can lead to heart attack, stroke, peripheral artery disease, and so forth. Also, osteoarthritis of the knees and the hips due to obesity and the inflammatory state of obesity, not just due to the mass that's on the joint weighing it down, but also because of that inflammation that literally eats away at the cartilage of the joints, independent of loading of the joint. So, and of course, there are many other things associated, obstructive sleep apnea. And also, many people don't know this. There are at least 13 cancers that are associated with obesity. Having excess fat mass is not a benign thing by any stretch of the imagination. Even if your sugar is normal or you don't have high blood pressure and your cholesterol is controlled, although frankly, I don't see that picture terribly often. Because the things that are driving the obesity, the poor dietary choices that go along with the standard American diet that we have here, which are high in refined carbohydrates, high in saturated fat, high in sodium, our generally sedentary lifestyle, our lack of sleep, our high stress, use of substances, all of the pillars of lifestyle medicine are kind of upside down for the average American who isn't paying attention to their health and is just kind of going along with what's typically done in our society. And the standard American diet, the acronym is SAD or SAD. And it really is because 50, 60 years ago, our lifestyles, our diet, our degree of physical activity were much better. So I focus on that, and I am board certified in obesity medicine as well as internal medicine. So I am dual boarded. We have a comprehensive lifestyle program here to support this particular goal. And that involves a certified health coach who assists our patients with setting goals and achieving them, getting around obstacles so that they can achieve them, some accountability. She meets with our patients on a weekly basis if they'd like to engage in that aspect of the practice. And we have an exercise physiologist as well, who's highly trained. He comes from a cardiac rehab background, but he's been working with people from actually pro athletes, cyclists, he's a cyclist himself, to average folks, to folks who are very heavy, have uncontrolled diabetes and so forth. And he's really able to help basically develop a bespoke and individualized fitness program for each patient that takes into account any injuries or limitations, but is challenging enough that we get results, instruct them how to do it, provide them with videos how to do it. So I also do nutrition counseling. I'm able to develop weekly meal plans for my patients, right down to giving recipes for every single meal that a person eats each day. And we can readdress that as needed. And of course, being certified in obesity medicine, I do also use the weight management medications as needed. And that ranges from the new ones like Wegovy and Zepbound to some of the older ones, phentermine, Qsymia, Contrave, the older oral medicines that can be helpful too. And especially if people don't have insurance coverage for the newer injectable GLP-1 or GLP-1 GIP medicines. So that's our weight management program. I should mention also I do body composition analysis with a bioimpedance device made in Germany. It's made by a company called Sika. I find it to be the best type of instrument for measuring body composition. And by that, I mean not just how much fat do you have, but where is it? Is it mainly under the skin, subcutaneous adipose tissue, or is there some accumulating around the organs? We call that visceral adipose tissue. And that's the most dangerous form of adiposity because fat in the pancreas disrupts insulin production and leads to insulin resistance diabetes. Fat in the liver is not a benign thing. Chubby liver, isn't that cute? No, it's not cute because fatty liver progressing to cirrhosis fibrosis is the most common reason that people need a liver transplant in the United States now that we can treat and cure hepatitis C, and that on average, we don't have so many alcohol problems. It can also lead, if it goes beyond fibrosis, to cancer of the liver. So not benign. And of course, any fat accumulating around the heart, we call that epicardial fat, can also be contributing to cardiac disease. So we need to know where the fat is, not just how much there is, and I can determine it this way. Also, I am measuring muscle mass. So skeletal muscle mass, really important to maintain. People can lose a significant amount of muscle mass if they're not paying attention to protein intake and strength training while they lose weight. And that's whether they do it just through lifestyle change or if they do it lifestyle plus medicine. Whenever you lose weight, if you're not paying attention and not monitoring it, because if you don't measure it, you really don't know, then you're at risk to lose that. And our length of life, as well as our quality of life, our health span, if you will, not just our lifespan, is directly related to two things. One is aerobic fitness. So you're what we call the VO2 max. How much oxygen can your body utilize per minute? That's your aerobic fitness, a measurement of it. But there's also the skeletal muscle mass. So your quality of life and the length of it directly related to both of those things. And if you basically help someone lose weight, but half of it is muscle mass, especially if they're an older person, basically you're putting them at risk for balance problems. Balance problems can lead to falls. Falls can lead to fractures. All of that much more likely if you have low muscle mass, what we call sarcopenia. So we really want to avoid that. If I'm helping somebody lose weight, like frankly, some of these online programs where there isn't any direct measurement of the patient's weight and body composition, and the patient's basically just telling the person remotely, a clinician of some stripe, what their weight change is. And we could really be doing a tremendous disservice to the patient. So that's the weight management program available to everybody in our practice. Now, I mentioned, that there's a second focus of the practice in terms of longitudinal long-term things, and that is screening for cancer. So I do that through two ways that are in addition to the regular cancer screening advised by the United States Preventive Services Task Force. Those guidelines are really just based on what does the government think that the United States health system can afford for people. So I'm referring to colonoscopy starting age 45. If you're a woman, a gynecologic exam with pap smear, mammography, beginning at age 40. Of course, both of those, depending, when I say both, I mean mammogram and colonoscopy, depending on your family history, might start earlier, depending on that. But otherwise, or if you have a significant smoking history for 20 plus years and you've quit in the last 15 years, to get a low-dose CAT scan of the lungs to screen for lung cancer if you're within a particular age window. But that's really about it. And there are, of course, many, many other cancers to be concerned about. And so I do it by two ways. I go deep with blood work. So I use something called the Gallery blood test made by the Grail company. While it's not covered by insurance, unless you're actually covered by TRICARE because you're in the United States military. They are covering it now. It is cash to the company, not to me. I don't make any money on the test, but I am able to give my patients a discount because I have a business arrangement, an account with the company. So I get a significant discount for my patients. And this is looking for cell-free DNA shed by dozens of different cancers, up to 53 currently, that shed into the bloodstream and allows us to detect the cancer. Now, it's not 100% sensitive or specific. No test is in medicine. And however, it is a good additional tool in the toolbox. It's a good adjunct to the regular screening for cancer. And what it allows me to do is also be particularly vigilant for some of the faster growing cancers that can unfortunately present themselves when it's too late, when they're stage 4, they've metastasized. These are things like pancreatic cancer and ovarian cancer. Because they grow rapidly, they outstrip their blood supply sometimes. Cells are dying off and all the DNA that is in their nuclei is shed into the bloodstream, and so they can be detected. So while not perfect, it's a very, very good additional instrument to use. The other one is an imaging instrument. It's whole body MRI. I utilize a company called Prenuvo. The closest one to our office in Great Neck, New York is in Manhattan near Penn Station. And whole body MRI does exactly what it sounds like. It is a screening MRI, basically from head to ankle or so, depending on how tall you are, looking for anything that doesn't belong, anything that's wrong. And, that could be just things like disc issues in the back or problems with the knees or a cyst in the kidney that's almost always a benign thing. But what we're really doing is making sure that we're looking for things that could potentially be malignancies. And we've caught things by both tests that wouldn't have been found otherwise. So it's really important in my mind to do these things. How often is kind of a discussion to have with me and any of your other doctors, but every 2 years I think is reasonable if you're able to afford the cost of these two things. So that's the annual physical. I do an EKG routinely on the physical and so forth as well. And the regular routine blood work that you come to expect, but I do focus on metabolic parameters, in particular cholesterol, more than some doctors do. You may have heard on our podcast about lipoprotein(a), which is a non-modifiable cholesterol marker in the sense you can't change it with diet or conventional cholesterol medicines like statins. And so it's largely genetic, and about 30% of the world population has an elevated Lp(a), we call it for short. And it confers a 2 to 3-fold increased risk for heart attack as well as stroke if it's elevated. And it's not checked routinely in the United States. It is part of the guidelines for cardiovascular risk determination in Europe and Canada. Frankly, I feel here in the States we're about 15 to 20 years behind the times in this regard. But I utilize this annually, this kind of testing. This test doesn't need to be done more than once in a lifetime because it is a fixed sort of genetically driven marker. But most people don't know that they have it. Unfortunately, the way people find out sometimes is that they have a heart attack in their mid-30s, their mid-40s. They had an LDL cholesterol that wasn't too high, maybe it was 120 or 130 or so. But they find out after the fact that their Lp(a) was 200, something north of the 125, where we really start to worry about it. And I don't want that to happen to my patients, of course. So we check that on the initial blood work we do when the patient joins the practice. I'm also checking insulin level and CRP for inflammation, on top of the routine things that we do, looking at blood counts and metabolic panel to check sugar, liver function, kidney function, thyroid, urinalysis, vitamin D level, vitamin B12, all the routine sorts of things you might expect at a regular physical. Now, I know I've prattled on for a while, but there's more, at the risk of sounding like a 2 a.m. infomercial. So I mentioned the acute things we do, of course, in the office. I'll see you for an illness, respiratory illness or low back pain or whatever the case may be, urinary tract infection, etc. However, I am available, as I said, pretty much at all hours. The office phone always rings directly to my cell phone. And if you call me in the middle of the night, as long as it's for something that's an emergency, not a medication refill, we'll have a chat. I'll pick it up. We'll have a chat. And if you're so sick that I really think you should be seen in the hospital, I'm not going to say, all right, call 911 or have your significant other drive you over to the hospital, depending on the issue, and best of luck. I actually meet you in the emergency department if it's within a reasonable distance from the office, if it's one of the local hospitals, particularly ones where I have privileges, which is helpful. And I'm going to advocate on your behalf. I'm going to make sure that they, first of all, have a very good history and understanding of who's presenting to them in the ER, meaning your history, your medications, your family history, your surgeries, what's been going on lately, if I've seen you recently in the office, which usually I have, and why you're actually coming in on that particular day at that particular time. Sometimes patients too sick to relate this to the staff. Maybe they've never been to that hospital before and there's no chart in the system to start with. But at the minimum, they're not going to be able to do a medication reconciliation with your pharmacy probably until the morning. And It's really kind of a bad place to start if you're a black box, you have no chart, the pharmacy's closed, you're really sick, no one's there to advocate on your behalf. You're going to languish in the back of the ER for 6 hours, 8 hours, whatever the case may be. Frankly, when your primary care doctor shows up 30 minutes after you got to the ER or what have you, you're going to be seen sooner. But most importantly, they're going to have a good understanding of what's happening with you and where to start. They're not going to need to throw the kitchen sink of imaging and blood work at you like they would if you were the so-called black box sort of patient. And I'm also there advocating, making sure things are happening that should happen, talking with the ER physician or other clinicians that are taking care of you in the ED. And if you get admitted to the hospital, if they want to keep you overnight and so I'm going to also advocate on your behalf with the primary team upstairs. Sometimes that's in a teaching hospital, that's internal medicine residents, especially if you go in July, the worst time of the year to go to the hospital, you may get some people who are very green in their new roles. The intern might have been a med student last month, and the resident running the team may have been an intern last month. And things happen, things get missed. Before I intervened on a patient, there was actually a case where they missed a kidney stone. Patient went in with her typical kidney stone attack picture, but needed oxygen in the ER. They didn't work up the reason. They discharged her home with an oxygen generator without working it up. I was called in to see her at home, and I couldn't get her oxygen level up with the oxygen generator. And not to pat myself on the back as a brilliant diagnostician, but the thing they hadn't ruled out that was the so-called elephant in the room was a pulmonary embolism, a blood clot to the lung. So I accompanied the patient and the family back to the ER and kind of raised heck and said, hey, I think you sent this lady home with a clot in the lung yesterday, and she almost passed overnight. It was good that I got to their apartment this morning, and lo and behold, they jumped. They got the CAT scan, the CT angiogram of the chest showed 2 clots. She got a private room upstairs. She got really close attention. I stayed on top of the staff up there. She was put on heparin and then transitioned to an oral anticoagulant called Eliquis so that she could essentially not have this happen again. We don't know why it happened. So she'll be on treatment lifelong to make sure it doesn't happen again. Long story short, now she's okay. But without having somebody advocate on your behalf, it's a big machine. I'm not faulting the doctors and other staff in the hospitals. They're doing their level best, but it's a big machine. They're overwhelmed and the system is somewhat broken. The broken nature of the system is the reason that I practice the way that I do in the concierge style, because this is not possible when you work for a hospital system as an outpatient primary care physician too. So that hospital advocacy piece is available to everybody in the practice. And I think it's very, very important. Now, if you want all of this, plus the full old-fashioned country primary care doctor a la Marcus Welby, if you've ever seen that old TV show. I also do house calls in the premier version of the plan. Now, like I said, this is executive health level of care. While we can take your insurance, the lion's share of your care is covered by a cash membership fee, which can be paid monthly or annually. It does cost a little more if we break it down monthly. If you were to utilize our services a great deal, like say you're a weight management patient, and I see those folks on a monthly basis, ideally, and you're using the health coach and the exercise physiologist, et cetera, it really breaks down to be a great value. However, if you want to know that I have your back should anything happen, I'm here for you. And if you really want to know that I will come to your home or your place of work, let's say you're a busy executive and you don't want to take the time to come to the office, you want me to come to you, the Premier plan allows for that. Also, if you're, say, an older patient with many, many medical problems and, you're often quite ill, possibly needing to go to the hospital, then your house call visits would be really appropriate for you too. So this is a kind of care that really solves the problems that are inherent in getting much worse in our standard medical system kind of practices that only take insurance. While it's not for everybody, it's really the best possible way to have somebody looking out for you who's also going to coordinate all your care with any specialists you have and so forth. Somebody who has the time to really know you and look after you properly. The reason I can do this is that instead of the 3,000 patients I had when I worked for the hospital system, I limit the practice to 300. So that way, I know everybody really well. I know their names. I know their families' names and what's going on with them. And when you come in, you're treated like family. bottom line. You're not just another medical record number being herded through the clinic as quickly as possible so they can get 30 patients seen by the doctor that day. So if you have interest, if you'd like to learn more, you can call the office directly. We are Northeast Medical Practice, 516-604-3418 in Great Neck, New York on Long Island, just outside the city. If you would like to learn more by reading and so on, visit our website, northeastmedicalpractice.com, where you have, of course, all of our social media channels. I have a YouTube channel. If you search for Northeast Medical Practice, you'll find it. And also, I have a podcast that I alluded to earlier called Longevity MD. It's available on Spotify. I interview other specialists such as cardiologists, urologists, etc., about topics that relate to optimization of health, either metabolic or cancer screening, etc. And I also give talks like the one I'm giving to you now on various medical topics that you can see and listen to on the podcast, or you can go to the YouTube channel. So again, everything that I've spoken about here for educational purposes only. If I've alluded to particular types of treatments or testing, I have no financial interest in them. And if you have particular medical problems, concerns that you want to speak to somebody about, please don't hesitate to reach out to your own medical professionals. And if you want to speak to us, please reach out to us. I'd be happy to chat with you. Until we see each other again, be in good health.